Hello everyone. Should I start, sir? Hello everyone. My topic is pearls to deal with rock hard cataract. Thank you AIOC and Dr. Owen Manto sir for giving me this opportunity. Here goes my presentation. We all know hard cataracts are tough nuts to crack. So the rate of intraoperative complications are much higher in case of rock hard cataract, and we need to analyze and strategize how to deal with such difficulties and come on with flying colors. So to win a battle, we have to actually know the strength and the weakness of the enemy. And here the area of concerns are the damage to the posterior capsule, damage to the zonular complex, and damage to the endothelium. There is some associated comorbidities like weak zonules, thin posterior capsule, compromised endothelium, pseudoexfoliation, and so. So here are the top 9 pearls and strategies to deal with a rock hard cataract. Number 1, capsular staining. You always use a trypan blue 0.06% in such cases, because here there is always a poor fundal glow, and there is associated corneal comorbidities like arcus sendalis or decreased endothelial count. So second is capsular axis. The capsular axis size should be moderately larger, that is 5.5 to 5.75 millimeter, not too small. For better intraoperative manipulations, here here the zonules are weak, so we have to our target is to less the zonular stress, and for any inadvertent condition, when we can convert the case into manual SICS, we can bring out the nucleus portion outside the bag. Then there is careful hydro dissection. Here fluid wave is not always visible due to dense nucleus. So to prevent capsular lenticular block or PC blowout, we have to target the multiple points of dissection and decompression, and don't be so aggressive, because in such cases we may have some posterior polar component also. Then right use of and proper use of the instrument. In this case, use a sharp, long chopper, that is 1.5 millimeter to 2 to 2.5 millimeter also, because here the nucleus is much harder. It is 8 to 10 millimeter in diameter and 4 to 5 millimeter in wide. So there is no use of the small chopper in such cases. Then proper and judicious use of the cohesive and dispersive viscoelastics. And proper tip exposure is always necessary to grasp the endonuclear core of the nucleus. And here balance tip is actually very useful, and whenever possible use new sleeve and tip in such cases. Hyperpulse technology, actually where the pulse is more than 50 per second, and it is introduced, the target is to reduce the heat due to the repeated on and off time, and there is a improved followability because of decreased chattering. Torsional phaco technology by Alcon. It actually break the nuclear by shearing effort, not by traditional jackhammer effect. And here the advantage is increased followability, decreased energy use, shorten the surgical time, and less endothelial damage. IP is actually a short pulse of longitudinal ultrasound, and after a preset maximum vacuum level is reached, and there is a clogging of the tip, and because of this there is a decrease of efficiency of the torsional ultrasound. So here we use a short pulse of a longitudinal ultrasound just to increase the efficiency of the torsional phaco. 5, using soft cell technique introduced by Dr. Steve Charles Arsinoff, and here we use the 2 viscoelastics. There first a dispersive one to protect the cornea, and then cohesive one to create a space and flatten the capsules. So I am using a soft cell technique in this video. To avoid initial wound burn, this step is very much important. When we enter into the anterior chamber, be ensure that there is a proper fluid flow in and outside the phaco tip, and remain in foot position 2, that is irrigation and aspiration, and when the occlusion till the occlusion sounds stop, Then you propagate into foot position 3, that is direct phaco power. Otherwise, due to the thermogenicity of the viscoelastics, there is a direct transmission of the heat energy to the incision site, and there is a wound burn. Then right technique of nucleus division. There is so many of technique, the stop and chop, divide and conquer, direct chop, but my preferred technique is phaco debulk chopping. If there is any epinucleus there, I use epinucleus shaving mode. Here power is 10%, aspiration fluid is 30, and vacuum is 250, bottle height is 90 centimeter. Then this is a chop setting. Here we are using burst, longitudinal burst power instead of torsional energy, because to hold the nucleus. And this is the complete cracking of the nucleus. To break the enemy, first attack his backbone. So I use this strategy. I first crack the nucleus into 2 halves, then actually fragment it into multiple pieces, 6 to 8, or as many as you can. Here we need a greater vacuum. I use a 700 millimeter vacuum, and aspiration fluid is 45 in these cases. Then quadrant removal, the tricks of the clear corneal, the immediate post-ops are minimum lens chatter and turbulence, posterior plane of emulsification, and using adequate OBD to protect the endothelium. In quadrant removal, I use 60% continuous torsional mode. Here aspiration fluid is quite higher for better fallibility, and vacuum is 700. Actually, in quadrant removal mode, there is a proper harmony between the phaco power aspiration fluoride, and here is the chopper shield technique described by Dr. Rohit Om Prakash, and here I using my blunt chopper in between the phaco tip and the corneal endothelium, just to protect the corneal endothelium from shattered fragments. The last fragment removal is very important. Here I using more viscoelastics, and using my blunt chopper to protect the posterior capsule to avoid any kind of surges. When in case of one single latent we cannot crack the nucleus into 2 halves, then multiple level chopping we can use this technique. Here we actually propel the nucleus into a deeper plane, and then try to separate laterally the nucleus. We have to be very, very patient in such cases. And always use hooks and rings when required in case of subluxated cataract, and in case of small pupil with rigid one or eye fish. And always know one thing, that there is an alternative of phaco, there is manual SICS. And the advantage of SICS is very safe wound covered by the conjunctiva. There is no wound burn, no excessive manipulation, minimum endothelium loss, no stress on the zonule, and minimum induced astigmatism, that is temporal MSICS. And last, no ego. Whenever things going tough, you can always convert the case into manual SICS or ECC for the better safety to the patient. And whatever maybe you think of about yourself, you are a big surgeon, great surgeon, don't hesitate to convert the wound when you are not comfortable. So I thank Dr. Wayan Mahanto sir, Dr. Arup Bhomik sir, Dr. Manos Ghosh, Dr. Minmay Das, and Dr. Shogato Borman. Thank you.